So we're going to be talking about the HPV self-testing, a new tool for increasing access for cervical cancer screening among women living with HIV in Zimbabwe. Allow me to give you an overview of the USAID-funded TASK program, TASK standing for Target, Accelerate, Sustain, Quality Care HIV program. Our main goal is to contribute to the achievement and sustainability of HIV epidemic control in Zimbabwe through the provision of comprehensive clinical care services in the national HIV program. So we are a consortium of 3 organizations, OFIT being the prime, GF Kapnik and ZNMP Plus. We are in 322 facilities, which are Ministry of Health facilities that we support. We are in 4 provinces, 15 districts, and we look after, or we support the care of 328,060 clients, with 41% of those being women living with HIV between the age of 25 to 49. So the background to our work, as you know, cervical cancer is a major concern, cause of concern globally, with the burden in higher countries with HIV prevalence being as six-fold higher a risk of developing cervical cancer. So Zimbabwe kind of like falls under that banner. This is attributed to human papillomavirus, which accounts for 95% of the cervical cancer cases. Significant and increased burden of cervical cancer in Zimbabwe in the last maybe decade or so. We're getting to see about 2,300 new cases every year and about 1,500 deaths, mortality rate about 64%. Cervical cancer is largely preventable through the screen and treat program for precancerous lesions, which rely solely on simple, inexpensive, easy-to-use tools that can be delivered at the lowest level of care. However, the average sensitivity for the VIAC program that we've been implementing, however, the sensitivity for our VIAC program shows that it is about 50%, ranging from 14 to 95, and specificity of about 85%. Screening in Zimbabwe has been scaled out, but not as fast as we'd want it to be. We still have about 120 facilities still, less than 120 facilities still offering cryotherapy. We also, the low screening demand and also the competing priorities for our health care staff. So the TASK program in 2023, just to give you an overview of what we did, we managed to see against our target, as we know that we're funded by USAID, 91% of our performance. We managed to see 63,813 women between the age of 25 to 49 for cervical cancer. And out of those, our positivity rate was 5%. And from those that we saw with precancerous lesions, we managed to treat 98% of those. Our support to the ministry in terms of the cervical cancer program, we are building capacity, training our healthcare workers as well as cadres who are not lay cadres in screening and treatment provision. I'll speak about the lay cadres in the next slides. We also provide nurses in high volume sites where they have more than 1,500 people living with HIV. We provide, through your major expertise, support to our VIAC nurses through the specialist gynecologists in all our supported districts and provinces. Screening of women with the HPV-DNA screening, VIAC, treatment of precancerous lesions, either by cryotherapy, thermoablation, or LIP. We also provide histology support through a private lab for the clients who would have had LIP in our supported facilities. We also do integrated outreaches. We have VIAC champions to support continuous quality improvement, and then local support in all our facilities. So the objective of our paper was to showcase the lessons that we learned through a pilot rollout of the HPV HPV-DNA screening that we conducted between March to June in Chitungwiza. So we just wanted to see the reach of the women living with HIV in the community. We also wanted to see the uptake and the screening rate of cervical cancer using HPV-DNA screening, the extent and decline of HPV in VIAC screening, and then the lessons learned and recommendations for practice. So as our methodology, we actually adopted the screening algorithm that was guided by the WHO. The guidance came out in June 2021, which talks about the screen, triage, and treat. So the screening model that was recommended, which has been taken up by the Ministry of Health, now is utilizing the HPV-DNA screening. For all the clients who become negative, we now don't need to see them on annual basis like we've been doing within the HIV realm, but we're now getting to see them every 3 years as long as they're HPV negative. And for those who are positive, we then continue to go and triage them using the VIAC in our setting. Again, if they become negative, we see them again in a year. If they are positive, then they are treated, their lesions, according to the size of the lesion. If the lesion is below 75% of the os, we're then treating them with either cryotherapy or thermoablation, depending what is available at the facility. If the lesion is above 75% and thicker, then we're recommending LEAP, which is then again given to the lady at a referral facility or within the district when a LEAP camp is happening. Again, post-treatment care is done annually. So for those clients who become suspicious of cancer, they're then referred on for further management as according to the ministry guidance. So in terms of the pilot phase that we're doing, the eligibility criteria was every woman who's been sexually active, whether you are widowed, whether you're single, as long as you've been sexually active at some point in your life, and you're 25 to 49, living with HIV and you are in care, you are eligible for this study. So the exclusion criteria were women who had a history of hysterectomy, women in menstruation, those who were pregnant, women who were less than 3 months following pregnancy, because we're doing this in the community, we needed to be very explicit. Whether you've had a baby or you've had a miscarriage, as long as it's less than 3 months, you were excluded from the study. And also women who came in with signs of invasive cancer. So during that pilot phase, we managed to see a total of 2,189 women were screened using the self-test tool. So sample collection was done at various points. I think what we needed to be explicit is what the sample collection was actually done in the community by lay cadres. We had a cadre who we called a COA, who was equivalent to a village health worker, who was capacitated in sample distribution, giving out of the information, who facilitated in the sample collection at either at an outreach point, door to door for pre-identified clients, an off-card point. An off-card is a DSD model within the HIV realm where a champion is identified in a particular catchment area. They offer their household, so medication and everything else is actually done at their household level as opposed to the OI clinic. So we utilize the same model in terms of self-collection of samples during this phase. We also recruited a bartender, a waitress, and a sex worker to facilitate distribution of kits within their catchment area and their circle of influence. So our results after the period that we're implementing, from the 2,089 samples we sent out to the lab, 2,000 results came back. 189 were still outstanding at the time of reporting because we'd run out of reagents. However, from the results that came, they constituted 91% of the work that we had done. 560 of those women were HPV positive, meaning our positivity rate was 19%, and 69%, 1,377, were negative. So going back to our algorithm, meaning those who were negative, they didn't need to be VIA'd, they didn't need to go to the facility. So it translated that all those women, we actually managed to decongest the facility by 7 out of 10 women living with HIV, which was a big leap in terms of implementation and programming of the cervical cancer program. Our turnaround of results was between 2 to 3 weeks, which was a challenge, but I'll show in the next slide. And the results which were outstanding were constituted for 9% of the cohort. So for the 560 that were HPV positive, we then went on to triage them using the VIAC model. Unfortunately, like I've highlighted, that our turnaround of results was pretty long, sometimes taking longer than even the 3 weeks. Because Chitungwe is a very mobile community, by the time you want to go back to look for that woman that you collected the sample, maybe they've actually moved from where they were living. So we managed only to get 56% of the women who were supposed to be triaged. However, of the 56 that we saw, our positivity rate for precancerous lesion was 9%. And 91% of those women, they were HPV positive, but they didn't have any lesions that needed treating. For those 28 that we saw, they were actually all treated according to the lesions that they had. As you can see, the bulk of our clients are treated by LEAP because of the thickness of their lesions when they present. So that one is just to show you, before we started the HPV-DNA screening, the VIAC screened, which was done exactly a year before, we managed to see 2,621 women. During the pilot phase, we managed to see 2,808. It speaks on the reach that we managed to do. With the introduction of HPV, we managed to see more clients because we're actually going into the community where they were living. Our positivity rate was at 3% during the period when we did the HPV-DNA screening, why it just speaks of the sensitivity and sensitivity of the HPV screening module that we're using. And also, it highlights some of the challenges that we've been having as a nation in terms of overtreatment of clients when we've used the VIA program without the HPV. So there we go. So during the pilot phase, the successes that we had, we didn't need to create a new program completely. We integrated with the programs which were available already. So it was quite easy for us to just say, the nurses who are doing VIAC are the ones who are going to be managing this program. The nurses who were already working in the community are the ones who are overseeing this program. So the registers and everything else just built into the work that we did on HPV. Identification of champions was pretty good in terms of spearheading the self-testing, because we know a lot of women do not want to come for VIA because of the speculum. So we managed to look for champions, especially within the KP environment. So they managed to collect their samples within their areas of work or at one of their houses. They didn't need to come to the facility, and we managed to see many clients. I think on the first day, we saw 63 clients in just one contact. The program was well received by women within the target group. I cannot emphasize that enough. Everybody was trying to run away from the speculum, so the brush was an easy thing for them because they were able to do it themselves. We decongested the facility because all the 65 clients that we saw, 69% of the clients, the 1,377, didn't need to go to the facility, didn't need to have a contact with a healthcare professional. So in this current season where we are, this couldn't have come at a better time. Self-testing kits, more acceptable, user-friendly, convenient, and empowering. So we also had bottlenecks. Remember, this is a learning phase. So in Chitungwiza, because the processing of the samples were done on a hologic machine. However, we didn't have a hologic machine in Chitungwiza, so all the samples were having to be taken to Mandara and back. As you can, this presented as a challenge in terms of turnaround of results and the flow of the work that we were doing. Results turnarounds being 2 weeks, delaying triaging and leading to client loss to follow up. Dissemination of results using the LIMB system was an issue because all our results needed to be in the community. Potential accidental disclosure of HIV status during a distribution. Remember, the clients that we were going for, they were pre-identified. So if a lady goes into a house where there are more women and she's wanting one particular person, there were questions maybe probably asked, why can I not do the same thing? So there was a potential of accidental disclosure of the HIV status in the community. And again, storage conditions, we were not guaranteeing the storage conditions of the sample, although the self-test kit can stay within 6 to 30 degrees without any challenges. But we weren't quite sure how these samples were being kept prior to getting to the lab or to the hub. So the lessons that we learned, that HPV-DNA screening, a community initiative, will increase the screening coverage for cervical cancer, simultaneously reducing unnecessary VIAC screening. Like I've already highlighted, if we look at the data that we used in 2023, 47,460 of the clients that we saw could have been seen in the community and not needed to go to the facility. Integrating services create a platform for adapting and adopting new initiatives, taking advantage of existing structures. Like in our case, we leveraged on the IST system for transportation of the HPD samples from the community to the lab effectively. Self-testing is a user-friendly and it increases the health-seeking behavior of target groups, especially the key population team that we worked with. Collaborative work is needed from the facility and the community teams for the success of HPV-DNA screening, screen, triage, treat approach in the cervical cancer program. These are our references for the work that we did. I would like to acknowledge the Ministry of Health and Childcare, the Chitungwiza City Council, the Department of Health, PEPFAR and USAID support, the Clinton Health Access Initiative, and the TASK Consortium. I thank you.